Hello everyone, welcome to HIM 216. We're covering Chapter 9 in your textbook in this lecture. And if you look on page 165 in your textbook, you will see that in Chapter 9 we are covering ICD-10 chapters 18 and 21. And that's because the codes from these chapters tend to be used throughout the other chapters, and so they go ahead and cover these first. Now, as always, I want you to look at the abbreviations and acronyms, and then I also want you to look at the glossary terms, and there are only 4 of them on page 185. I'm going to try to get through this lecture, through this chapter in one lecture, and so we'll see how the time goes. So anytime we're coding from a particular chapter, I always like to take you to the chapter. If we go to chapter 18, you will see that there are some notes here and excludes note 2. This note applies to this entire chapter, and this excludes note 2 applies to this entire chapter. You can see the section list that is listed here. We have a lot of general symptom codes, some abnormal finding codes. I think it's always a good idea to look through the chapter and see what you're going to be dealing with. So we know that chapter 18 is our sign and symptom chapter. We also know that we have some very specific guidelines that can be challenging about whether or not we can actually use a code from chapter 18. The other chapter we're coding from is chapter 21, and these are Z codes. And it says that we're covering codes R00 through R99 and Z00 through Z99. And those R codes are from chapter 18, and the Z codes, Z00 through Z99, are from chapter 21. And when we look at chapter 21, we have a note here, and this note applies to all of the codes in this chapter, and then we have the section list, and it's always, again, a good idea to go through and look at the different types of sections that are in each of these chapters. And of course, chapter 1 is factors that influence the health status of a patient, so it may not be a condition or a disease at all. Please look on page 166 in your book, and we covered signs and symptoms in chapter 5, so I'm not going to take a lot of time to go over these. It's sufficient to say that if a condition is integral to a disease process, that we do not code it. And if you look on pages 168 and 169, your book defines a symptom for you. This is objective evidence. This is typically what the patient tells the doctor. This is what's wrong with me. I have a sore throat. That's a symptom. The sign is objective. This is the result of the physician's exam. So the physician examines the patient and says they have strep throat. So you need to know the difference between a sign and a symptom. And your book does tell you on page 169 that it can be difficult to know whether or not a sign and symptoms associated with a disease process routinely or is integral to it. And so they suggest that you use the Merck manual to look up the diseases, and it will tell you what signs and symptoms are. And in the integrated code book, if you click on the references, you will see the Merck manual listed right here, and you can go into that Merck manual, and the diseases are listed alphabetically. You can also research them online as well, but it needs to be a reputable website. Now, when we're talking about signs and symptoms, we can code a sign and symptom. So we can code from Chapter 18 if we do not have a definitive diagnosis. So a patient comes in with chest pain and they leave with chest pain. They never determine why that patient's having chest pain. If the sign and symptom is not an integral part of the disease process that the patient has, on page 170, if the classification tells you to assign an additional code, and you'll remember that, let's see if I can remember this code. When we looked at the code for benign prostatic hypertrophy, N40. Here we have an instructional note that tells us to use an additional code for the symptoms when they are specified. And then also, if that sign or symptom affects the patient condition or the treatment that's being given to the patient, it would be coded. We do not code a sign or a symptom when we have a definitive diagnosis or when it's integral to the disease process. And then you have some examples here to review. We have gone over these types of examples before. Going back to page 166. If we have a combination code that includes a symptom, then definitely we code it, and an example is acute cystitis with hematuria. And if we go to category M30, we will see acute cystitis with hematuria, acute cystitis without hematuria, and so certainly we would choose the code with hematuria if in fact they had it. There's a code for repeated falls, and if your patient is being diagnosed with repeated falls, you can look it up by repeated, and it actually takes you to that code. If patient's falling, if they have a tendency to fall. There is an excludes note too here. If you have a patient who's at risk for falling, there is a different Z code for that. If they have a history of falling, it goes to the same Z code as risk for falling. So they may have repeated falls and they may be at a risk for falling, and you may have both of those codes on the same chart. There is a coma scale. And actually, in the new coding guidelines, they have expanded the coma scale. It can also be used to assess the status of the central nervous system for non-trauma conditions, such as patients who are being monitored in an ICU unit. And that's in the new coding guidelines. Excuse me, my headset's giving me a little trouble. And there are, when we go to these, to the coma scale, you'll see it's in Chapter 18. Category R40.2 are these codes. You do have an instructional note here. You have to code first any associated skull fracture or intracranial injury, and then based on the documentation in the record, if they're using the coma scale, you can code it. If they're not using it, obviously you cannot code it. And there is a 7th character that applies in these for these categories. Now there is also in the guidelines, in the new guidelines, there is also documentation about the National Institute of Health stroke scale. So if the stroke scale is being used in your facility, you now are able to actually assign a code for that. You'll notice that there is an instructional note that you have to code first the type of cerebral infarction. And to get to this, I had to put an NIH-SS. If I try to put in scale or stroke, it doesn't come here. Let's see if I put in score. Yeah, if I put in score, it will go here. But you have to remember that you're not going to be able to put in stroke or scale. You're going to have to put in score or NIHSS. Now, on the top of page 167, we have a note about functional quadriplegia. Functional quadriplegia is when a patient has an extreme debility and they simply cannot use their limbs or they cannot ambulate. This is not the same as a neurological deficit or injury. This is not a patient who has a spinal cord injury. This is a patient who is so debilitated and so weak that they can't use their limbs, and it's not because they have any nerve or spinal cord injury. So that's functional quadriplegia is very different from neurological quadriplegia. Systemic inflammatory response syndrome we will study in another chapter, and we'll actually study this guideline again, but it basically tells us that patients can actually have a systemic inflammatory response either from an infection or from a non-infectious process. And basically that non-infectious process is sequenced first, and then we add the code for the SIRS. And I can put well, I thought I could put SIRS in here, but I can't. If I put in systemic, you can see at the very bottom, systemic inflammatory response of non-infectious origin, and that code is R6510. If there is organ involvement, then the code is R6511, and these are examples of organ dysfunctions. You also have to code those. We'll code this in more detail in an infectious disease chapter. Then we have a death NOS code, which basically you will not use. There is not a time when we just diagnose somebody as dead. And so this is, it just really would not be used. I want you to answer for in exercise 9.2 on page 171. I want you to answer questions 1, 3, and 7. So exercise 9.2, page 171, 1, 3, and 7. Now we're going to take a look at the coding guidelines for chapter 21. And some of these codes can be used as a principal diagnosis. Some can only be used as a principal diagnosis. Some can either be a principal or secondary diagnosis, and some can only be a secondary diagnosis. I want you to look at this list of terms on page 171. It can be very challenging to try and find Z codes in the index. I come back and look at this page all the time to remind me of terms to look up to try and find Z codes in this index. It's not always very easy. Now, some Z codes we use regularly, and I think you should write those down if you become a coder. The Z codes you know you use on a regular basis, you'll probably remember, but there may be some that you don't use as often and you need to write them down. There are some that we use fairly often are screening codes. And you can see all these screening codes here that start with a Z. Now the thing with a screening code is that means that there is not any other diagnosis. There's no sign, there's no symptom. If there is, it's not going to be a screening code. And the classic example is in your book, and this is a breast exam. A patient goes in to have a screening mammogram. If there is any symptomology, if they have nipple discharge, if they have a breast mass, it's not a screening anymore, and you use a diagnosis code for that. We have looked at history codes. Now, when we go into history, the first subcategory is family. If we want personal history, we have to put a comma and begin typing personal history. So be very sure that you are choosing the correct history code when you're looking for personal history and family history. Now, it's very important to understand that there may be documentation of history of when in fact the patient has it. If they say the patient has a history of hypertension and they're on medication, they have hypertension and you're going to code that. If they have a history of diabetes, they have diabetes. If they have a history of COPD, they have COPD. So these chronic disease processes typically do not ever go away. Once you've got them, you've got them. The patient has to be monitored for them. They have to be checked for them. And so you're going to code that disease process and not the personal history of. And your book has some examples, and you can work back to those examples. Now on page 174, I'm not going to read and go over all of these guidelines. I'm going to point certain things out to you. Like for the contact exposure codes, these are codes in category Z20. And it tells you, the last sentence here is that these codes can either be a first listed code or they can be a secondary code. Inoculations and vaccinations, these are secondary codes. They are not used as principal diagnosis codes. There are a lot of status codes. And if we go to status in the index, there's lots of codes there. And these status codes, they can indicate that the patient's a carrier of a disease, or they have a sequela or a residual of a past condition. The status code provides you with information that can impact treatment. A status code is not the same as a history code. The history code indicates the patient no longer has the condition. A status code, they still have it. Now, you should not, in that second paragraph, it tells you a status code should not be used with a diagnosis code if the diagnosis includes the information provided by the status. For instance, the example they have, Z79.1 is a heart transplant status. If the patient is having a complication of a heart transplant, you don't need to have a code that says they've had a heart transplant because you know it's already in the complication code. So be very careful with that. Allergy status codes are included here as well. Now, there are notes here about TPA, and if you're going to be coding in a facility and you're going to be coding stroke patients who've received TPA, you need to really look at this guideline and make sure that you understand this guideline. It gives you guidance on TPA administered in your facility, in receiving a patient that's gotten TPA from another facility. So be aware of that. And then we have code on page 176. We have code Z98.85. This is a transplanted organ removal status, and it tells you that this patient had a transplanted organ and that organ was previously removed. You would not use this code. It should not be assigned for the encounter in which the organ's being removed. So it's only used after the fact to reflect that the patient had one and it was removed, not the fact that we're removing it now. Screenings discussed again on page 177. It can be a first listed code if it's the reason for the visit. This is an outpatient setting. You typically would not have an inpatient who had a Z code screening code as their principal diagnosis. It's also important to know that that screening code is not used if it's inherent to a routine exam. So if a patient has a pap smear done as a part of a routine pelvic exam, you're not going to have a screening code to go along with that encounter. Observations on the bottom of page 177, and this is very important to understand. We use the observation codes only if we were observing someone for a condition that was ruled out. It means we thought they had something and they had nothing. There's nothing to code. So we're coding using an observation code. Now, it's important to note that for 2017, they actually added a third observation code. There are 3 now. That code is Z05. You'll find it in the updated guidelines. And this is actually a code for a newborn that that was being kept in the hospital for a suspected condition that they didn't have. And we'll actually talk more about that when we're studying Chapter 16 in ICD-10. Aftercare is discussed. Aftercare codes can be first listed codes followed by the diagnosis code if the patient's only coming in for certain types of treatment, chemotherapy, immunotherapy, or radiation therapy. And in fact, it's the first listed code, and then the condition is listed as a secondary code. A patient can be coming in for both radiation therapy and chemotherapy. Either of those can be listed as the first listed code. For injuries, the aftercare code is reflected in the 7th character of the acute code. For instance, let me show you. I've shown you this before. So if my patient is coming in for aftercare as a result of a fractured femur, there is actually the 7th character of sequela that we possibly would use for this, but we also have a subsequent encounter code. We have delayed healing codes, and so that aftercare is going to depend on what is being done for that patient. In your book on page 179, it talks about follow-up. We can't confuse follow-up and aftercare. Follow-up are when we're doing continuing surveillance on a condition that's completely gone, a condition or an injury. An example of that is if we have a patient who's coming in 5 years after they've completed treatment for cancer. That's a follow-up code. To look up the code for donor, in the index we put in donor, and here are the different types of organs and things that can be donated. And on the flip side of that, there are times when patients may elect to have a prophylactic removal of an organ. So prophylactic organ removal for neoplasia management, breast, ovary, or specified NEC. So we look up prophylactic for that. And that's actually on page 181. Prophylactic is. On page 180, we have counseling. Typically, these would not be used in an inpatient setting, and it's very important to know that if counseling is done in conjunction with a diagnosis code, then the counseling component is considered to be integral to that treatment. So if a physician documents that the patient was counseled to stop smoking, that he counseled the patient to stop smoking, and you have that diagnosis code of tobacco abuse, you would not have an additional code for counseling. Now, number 11 on page 180, we will also study this when we are studying this particular chapter. It's chapter 15 in ICD-10. But we have in the guidelines, category Z34 is a code that tells us the week's gestation. Well, let me put in there. The week's, okay, we have to go to pregnancy and then week's gestation. The week's gestation of an OB patient. And you'll notice we have at the bottom here, we have less than 8 weeks. It's not Z34, it's Z3A. I apologize. So Z3A for weeks gestation. And we can have not specified or less than 8 weeks, and then it goes up from there, and the last two characters correspond to the weeks. So 12 weeks is Z3A.12, 15 Z3A.15. The new guidelines that have come out have told us that if the patient has an abortive outcome, we are not using these codes, these weeks gestation codes. So if the patient comes in and they have a miscarriage, we're not going to use these codes. If they come in for an elective termination of pregnancy, we are not going to use these codes. And if they're coming in with a postpartum condition, we are not going to use these codes. So 3 instances when we do not apply the weeks gestation: abortive, elective termination, and postpartum, and that's in the new guidelines. Number 12 on page 180 talks about Z codes that we use with newborns. The one that you will use the most comes from category Z38, and this indicates that where the baby was born, whether they were born vaginally or by a C-section, in the hospital or outside of the hospital, if it was a multiple birth. And we'll go over these in detail when we're studying Chapter 16 in ICD-10. Every newborn baby, and if they're not alive, they're not coded, they don't have a chart, every newborn baby has a diagnosis code from category Z38. It's always their principal diagnosis code. It's the only time in their life that it will ever be used. If we look at number 13, when we're looking at abnormal examination codes, there are codes that say with abnormal finding and without abnormal finding. There are codes for patients who come in just for pre-op exams. You'll find those listed on page 121. On page 182, non-specific Z codes. Basically, the guidelines are telling you that you will probably never use those codes. And then number 16 on page 182, these are Z codes that can only be a principal or a first listed diagnosis code. So you'll see that list. I want you to come on page 183, exercise 9.3, I want you to answer questions 11, 13, and 15. So on page 183, exercise 9.3, answer 11, 13, and 15. Now, for your homework, you're only doing the chapter review for this chapter, not the workbook. So for the chapter review exercises, you're doing odd 1 through 33. And for chapter, let me see, I'm going to go down these questions. For questions 1, 3, and 5, there is 1 code. 7 has 2 codes. And then 9, 11, 13, 15, 17, and 19 all have 1 code. 21 has 1 diagnosis code and 1 procedure code. 23 has 1 code. 25 has 2 diagnosis codes and 1 procedure code. 27 has 1 diagnosis code and 1 procedure code. 29 has 3 diagnosis codes and 2 procedure codes. And 31 and 33 have 1 diagnosis code each. Now I'm going to tell you for question 31 that the code is R99, because that sometimes students just spend way too much trouble trying to find that code. Number 23, remember what we said, if there's an abnormal finding, it's not going to be a screening code. And I think that for the rest of these questions that you should not have a problem with them. But if you have any questions, let me know. And that will conclude this one lecture for Chapter 9.